Welcome to the deep dive. Our mission, as always, is pretty straightforward. We take complex stuff today. It's a key chapter on specific learning disorder from Kaplan and Sadock's psychiatry textbook. And,
Yeah.
well, we break it down. We want you to walk away really getting it.
hmm
So today's topic is specific learning disorder, SLD. It's a neurodevelopmental thing affecting, honestly, millions. But maybe start with this surprising fact. Humans, biologically, aren't wired to read, write, or do math.
That's absolutely right. These are actually, relatively speaking, very recent cultural inventions. I mean, reading's only about 5,400 years old.
Wow.
Yeah, so our brains didn't evolve specifically for them. To acquire these skills, the brain has to do this massive reorganization, you could say. It has to actively recycle neural networks that were originally for other things.
Like what?
Well, the classic example is the visual word form area. It's in the left visual cortex. Probably started out recognizing objects, but when you learn to read, it gets repurposed for recognizing words.
Okay, so the brain adapts. But for
Yeah.
some people, this adaptation, this recycling process, it's just persistently difficult.
Exactly. And that's where SLD comes in. The DSM-5 suggests it affects at least 6% of children.
So today we're really digging into the core psychiatric ideas, the diagnosis, the causes behind this disorder, all based on this chapter.
Okay, so when we talk about SLD, what are we defining? It's a neurodevelopmental disorder. And the key is marked persistent difficulties. Difficulties learning and actually using these cultural symbol systems.
Letters, numbers.
Precisely, the things you need for skilled reading, writing, arithmetic. And it's crucial to understand this is a specific deficit.
Right. So it's not because someone has an intellectual disability overall, or they can't see or hear properly, or they just haven't been taught.
Correct. It's none of those. It's really a neurological difference impacting these specific academic skills in people who are otherwise developing typically. The textbook actually puts it quite starkly. SLD represents the extreme bottom end of the normal distribution of these culturally learned skills.
Oh, it's on a spectrum. But these individuals are really struggling at one end.
And to really get why someone struggles, say, with reading, we need to unpack the building blocks they're having trouble with.
Okay, let's do that. Let's maybe focus on reading first. So reading depends on understanding that spoken words are made up of sounds, right? These tiny units.
Yes, the foam. That's the smallest sound unit that changes meaning. Like the B in bat versus the C in cat. That tiny sound difference makes it a whole different word.
Got it.
And the real challenge often lies in phonologic awareness. That's the explicit, conscious awareness that spoken language is built from these smaller parts. It usually develops pretty early.
And you need that awareness for reading.
Absolutely. It's fundamental for decoding written language. If you can't really hear or manipulate those distinct sound units in your mind, mapping them onto letters becomes incredibly difficult, almost impossible to do reliably.
And that mapping, that's the alphabetic principle, right?
Yeah.
The idea that these squiggles on the page, the letters, actually stand for the sounds we make.
Exactly. And this is where the complexity of English really becomes a factor. It's about something called orthographic transparency.
Okay, what's that?
Well, English is what we call a deep orthography. The spelling to sound rules are really inconsistent. Think about words like tough, through, bow.
Right, same O spelling, totally different sounds.
Precisely. Compare that to a shallow orthography, like, say, Finnish. In Finnish, the letters and sounds have a much more predictable, almost one-to-one relationship. So you can see how an underlying weakness in phonologic processing would cause much bigger problems for a kid learning English than for a kid learning Finnish.
That makes total sense. It's a much harder code to crack.
Definitely. And this brings us to why clinicians, doctors and psychologists, need to be aware of this, even if it seems like just a school issue.
Because it's not just about grades.
Not at all. The clinical significance is huge, especially because of the really high rates of comorbidity. SLD often doesn't travel alone.
Comorbidity meaning other conditions occurring at the same time.
Yes. The most common one we see alongside SLD is ADHD. Some studies cited in the chapter found over half, like 54.9% of kids with SLD also had ADHD.
Wow, it's high.
It is. But we also see higher rates of anxiety disorders, mood disorders, even disturbingly increased suicide risk. So if a clinician is assessing someone for anxiety or depression, they really should be screening for an underlying SLD too.
And it affects practical life skills too, doesn't it? The chapter mentioned health literacy and health numeracy.
Yes, crucial concepts. Health literacy is basically being able to get and understand basic health information to make decisions.
Like reading instructions on a medicine bottle.
Exactly. And health numeracy is related. It's about understanding quantitative health information. Things like drug dosages, risks presented as probabilities, appointment times.
Okay.
And the scary thing is, having poor reading and numeracy skills, which are direct symptoms of SLD for many, is an independent predictor of worse health outcomes, even higher mortality rates.
So if you can't understand the instructions for your medication or calculate the right dose, the consequences could be really serious.
Absolutely severe, which is one reason why getting the definition right matters so much, and why there's sometimes tension between how the medical world defines it and how the educational system handles it.
Right. The school system uses the term learning disabilities, often based on different criteria.
Historically, yes. Schools providing services under the law, IDA, often relied on this pretty controversial model, the IQ achievement discrepancy.
Explain that. What was the issue?
Well, the basic idea was that your academic achievement score had to be significantly lower than your measured IQ score to qualify for services.
Okay, seems logical on the surface.
Well,
maybe.
But it created this huge problem. It essentially failed kids who were bright but still struggled profoundly. Imagine a gifted student with a severe reading deficit. Their high IQ might allow them to compensate and perform at grade level, even though they're working 10 times harder than everyone else.
So they wouldn't show a big enough gap between IQ and achievement.
Exactly. So despite having a real underlying cognitive weakness that meets the clinical definition of SLD, they wouldn't qualify for help in school. It punished the kids who were compensating the best.
That seems incredibly unfair. A flawed system.
It really was. Thankfully, the psychiatric classification, the DSM, has moved away from that. The history, as interesting terms, evolved from word blindness back in the 1890s to things like dyslexia for reading, dyscalculia for math.
Right, those terms are still used sometimes.
They are, often informally. But DSM-5 made a deliberate shift, uses one big umbrella term, specific learning disorder. Then you use specifiers to detail which academic areas are actually affected reading, written expression, mathematics. And crucially, it dropped the IQ discrepancy requirement.
Okay, that seems much clearer and fairer.
Yeah.
So let's get into the why. What does the textbook say about the causes, the etiology?
Well, the field has definitely moved past searching for a single cause. It's much more complex.
No silver bullet.
No.
Yeah.
The current thinking is framed by the multiple deficit model, or MDM. It basically says SLD comes from a complex mix and interplay of genetic predispositions, neurodevelopmental factors, and environmental influences. It's never just one thing.
Let's break that down. Genetics.
Huge factor. SLD is known to be moderately to highly heritable. Genetic factors account for, over 50% of the variance we see in these skills in the population.
So it runs in families.
Very much so. And what's really fascinating is something called the generalist genes hypothesis.
Okay.
It suggests that genetics account for something like 80% of the overlap, the covariation, between different academic skills like reading, spelling, and math.
Wait, so you're saying the same set of genes might influence difficulties in both reading and math?
Largely, yes. It suggests that the underlying genetic vulnerability isn't necessarily specific to reading genes or math genes. It's more about genes that affect broader cognitive processes, things like working memory, processing speed, which are needed to acquire any of these culturally transmitted skills.
That's a paradigm shift. So the vulnerability is general, but how it shows up can be specific.
Precisely. And when we look at the brain, the neurological substrate, we can see how these vulnerabilities might manifest in specific areas. For reading difficulties, what we often call dyslexia, brain imaging studies tend to show reduced activation in certain left hemisphere regions, temporal, parietal, fusiform areas.
Including that visual word form area you mentioned earlier.
Exactly. Some theories suggest it might be related to sort of a disconnection in the white matter pathways connecting these areas.
Okay. And what about math difficulties? Dyscalculia.
There, the evidence seems to be converging on a different area as a key locus of difference, the right intraparietal locus.
So different primary brain regions implicated depending on the specific academic weakness, even if the underlying genetic risk factors overlap somewhat.
That seems to be the picture emerging.
Now, beyond the brain structure, what about the cognitive processes themselves? You mentioned working memory and processing speed.
Yes, these are considered more domain general cognitive deficits, often seen across different types of SLD. Let's take working memory deficits.
That's like your mental workspace, right? Holding information in mind while you work with it.
Exactly. If that's weak, it impacts learning in many ways. For someone trying to write, they might struggle to hold their main point in mind while figuring out sentence structure or smelling.
Or for reading comprehension.
Absolutely. It makes it hard to monitor the meaning of what you're reading as you decode complex sentences. You lose the thread.
Okay, and the other one was slow processing speed.
Right. This is often measured using tasks like rapid automatized naming or RAN.
RAN, what's that testing?
It's simple. How quickly can you name sequences of very familiar things, letters, numbers, colors, objects presented visually? People with SLD often show significantly slower times on these RAN tasks.
So it's not about knowing the letters, but accessing the names quickly.
Precisely. It reflects a general slowness or inefficiency in retrieving and processing basic information. It makes academic tasks feel incredibly laborious, like you said, driving with the brake on.
Got it. And we mentioned environment earlier, too. How does that fit in?
Well, while genetics are strong, environment still plays a substantial role. Shared and non-shared environmental factors can account for maybe 40–50% of the variation in academic skills.
Like what kind of factors?
The chapter points to things like prenatal exposure, tobacco smoke, alcohol. These are linked to adverse neurodevelopmental outcomes generally and lower academic achievement. Also, things like low birth weight and prematurity increase the risk for SLD, particularly, it seems, for difficulties in mathematics.
So a complex web of risk factors. Genetics, brain differences, cognitive processes, environment.
It all interacts, which makes diagnosis tricky, but also underscores why a single explanation just doesn't work.
Okay, given all that complexity, how does SLD actually look in a person? What are the clinical features clinicians watch for?
Well, the key is that the difficulties are persistent, but they can look different at different ages as the demands change.
So what might you see in a very young child, say, preschool?
The signs can be subtle then. Maybe trouble learning nursery rhymes, difficulty with counting, consistently mispronouncing familiar words, maybe not recognizing the letters in their own name yet.
Things that might get missed easily.
Often, yes. But then in the primary grades, it usually becomes more obvious. You might see a real reluctance to read aloud in class. Reading is slow, very effortful, inaccurate. Maybe the child guesses words based just on the first letter.
I've seen that.
Yeah. Or for math, difficulty remembering basic facts, like 3 + 2 = 5. Still relying heavily on finger counting long after peers have stopped.
Okay. And then later on, high school, adulthood. Does it go away?
Generally, no. The underlying deficit persists, though people develop coping strategies. But reading likely remains slow and tiring. They might need to reread things multiple times to get the meaning. They might actively avoid tasks that require a lot of reading or writing.
Spelling issues, too.
Oh, often terrible spelling is a hallmark that persists. Sometimes misspelling the same common word multiple different ways, even in the same piece of writing. And for math, maybe significant math anxiety, difficulty applying arithmetic in daily life, like calculating a tip or managing a budget.
It sounds exhausting, honestly.
It absolutely is. And that brings us to a really crucial point the chapter emphasizes, the emotional toll. This isn't just about academic struggle, it carries a heavy emotional burden.
Like low self-esteem.
Definitely. Chronic embarrassment, feeling stupid despite being intelligent in other ways, high levels of anxiety, depression, and as we mentioned, even an increased risk for suicidal thoughts and behaviors.
That's serious. So sometimes the mental health symptoms might be what brings an adult to a clinician, and the SLD itself is hidden.
Very often, yes. Especially if they've developed good coping strategies over the years. The underlying learning issue might be masked, but the emotional fallout is what becomes clinically apparent.
Which makes diagnosis really important. How is it formally done, according to DSM-5?
Okay, so the diagnosis is purely clinical. There are no blood tests, no brain scans that can diagnose it definitively. It requires the clinician to synthesize information from multiple sources.
Like?
History, developmental history, family history, educational history, school reports, observations from teachers, and importantly, results from standardized, individually administered achievement tests.
Okay, and the DSM-5 has specific criteria, right? What are the key points?
Right. There are 4 main criteria, A through D. Criterion A focuses on the presence of specific symptoms. You need at least 1 of 6 listed symptoms, things like inaccurate or slow word reading, difficulty understanding meaning, poor spelling, problems with written expression, trouble mastering number sense or calculation, difficulty with mathematical reasoning.
Just one symptom.
At least one, yes, but here's the kicker. It must have persisted for at least 6 months, despite targeted help or interventions having been provided.
So that rules out just a temporary lag or poor teaching. It showed the difficulty is intrinsic and persistent.
Exactly. Then criterion B is about the impact. The person's academic skills in the affected area have to be substantially and quantifiably below what's expected for their chronological age.
Substantially below. How is that measured?
The chapter mentions a common guideline used in research and clinical practice. Performance on standardized tests that's at least 1.5 standard deviations below the population mean for their age. That translates to roughly the 7th percentile or lower.
Okay, so objectively low performance.
Yes. And crucially, these skill deficits must cause significant interference with academic achievement or occupational performance or just activities of daily living that require those skills. This is where the link to functional impairment comes in and why the IQ discrepancy is no longer needed. We're measuring the skill against age norms and looking at real-world impact.
Makes sense. What's criterion C?
Criterion C is about onset. The difficulties must have begun during the school-age years. They might not have become fully obvious or impairing until later, maybe when academic demands increase significantly, like in high school, college, or a demanding job. But the roots have to be traceable back to those school years.
Okay. And D?
Criterion D is the exclusion clause. The difficulties can't be better explained by other things like intellectual disability, uncorrected vision or hearing problems, other mental or neurological disorders, lack of proficiency in the language of instruction, or just inadequate teaching.
And you need to specify the areas affected, right? Reading, writing, math.
Yes, you must specify all academic domains and subskills that are impaired. And you also specify the current severity, mild, moderate, or severe, based on the degree of impairment and the amount of support needed.
And you mentioned distinguishing it from intellectual disability.
Right. In intellectual disability, the cognitive deficits are more global, affecting overall intellectual functioning and adaptive behavior across many domains. In SLD, the person typically has average or above average general intelligence, but a specific weakness in one or more academic areas. And you also have to consider co-occurring conditions like ADHD. They can exist together and often do, so you diagnose both if criteria for both are met.
Okay, so diagnosis is a careful clinical synthesis. If SLD is diagnosed, what does treatment look like? Is it medication? Therapy?
This is really important. The primary treatment for SLD itself focuses almost exclusively on academic intervention. It's educational, not medical in the traditional sense. There's no medication that directly treats the core learning deficit of SLD.
So the intervention happens in schools, mostly.
Primarily, yes. Carried out by specialized educators or learning specialists. The role for the medical provider, like a psychiatrist or pediatrician, becomes more about coordination.
Coordination
Like providing psychoeducation to the patient and family, explaining the diagnosis, monitoring for those common co-occurring conditions like anxiety, depression, ADHD, and treating those if they're present. Also advocating for appropriate academic accommodations and services.
Makes sense. And does this specialized academic intervention actually work?
The chapter makes a very strong case for it. It contrasts standard classroom instruction, which might only yield tiny gains for these students, maybe 0.04 standard deviations per year.
Which is basically nothing if you're already behind.
Exactly. But it highlights research showing that intensive, individualized, explicit instruction, really targeted, evidence-based teaching methods can produce dramatic gains. We're talking about maybe 35 to 70 hours of focused instruction leading to significant improvement.
That's hopeful. Explicit instruction meaning.
Meaning directly teaching the underlying skills like phonemic awareness, decoding strategies, number sense concepts, step by step, with lots of practice and feedback, not just assuming the child will pick it up implicitly.
And you mentioned something truly fascinating earlier, that this kind of instruction might actually change the brain.
Yes, it's still preliminary evidence, the chapter notes, but some neuroimaging studies suggest that this kind of intensive, focused intervention may actually help to normalize or alter those aberrant brain activation patterns we see in people with SLD.
Wow. So the brain can rewire itself, at least to some extent, in response to the right kind of learning experience. That's profound.
It really is. It speaks volumes about neuroplasticity, even in the context of a neurodevelopmental disorder.
But what's the long-term picture? Does SLD just go away with intervention?
Unfortunately, the general prognosis is that SLD is typically a persistent chronic condition. It usually lasts a lifetime.
So even with good intervention.
Even with intervention, while skills can improve significantly, like someone's word reading accuracy might get much better, the underlying processing differences often remain. So, reading might still be slower, more effortful than for peers without SLD. Writing might continue to be a struggle. The chapter points out that the achievement gap, especially in reading, often appears as early as first grade and tends to persist right through adolescence and into adulthood, even if it narrows somewhat with support.
So it's about management and compensation over a lifetime, not a cure.
That's a good way to put it. Lifelong strategies, accommodations, and understanding are key.
Okay, let's try to wrap this up. If we were to recap the absolute core takeaways from this deep dive into the Kaplan and Sadock chapter.
Well, first, SLD is common, it's neurodevelopmental, and it's significantly heritable.
Right. Defined by those persistent specific problems, learning the cultural tools, reading, writing, math.
Second, diagnosis is clinical. It relies on synthesizing history, reports, and importantly, standardized testing showing skills are substantially below age expectations, causing real-life impairment. And critically, we've moved beyond that flawed IQ achievement discrepancy model.
Good riddance to that.
Indeed. Third, treatment isn't medication for the SLD itself. It's intensive, explicit, evidence-based educational intervention.
But the clinician's role is still vital for coordination, managing comorbidities like anxiety or ADHD, and advocacy.
Absolutely. And finally, prognosis is generally lifelong persistence, meaning management and support are key.
So maybe a final thought to leave our listeners with. We've talked about these skills being cultural inventions, things we have to learn. Given that maybe up to 10% of people have this lifelong disorder affecting their ability to access and use these fundamental skills, skills needed for everything from jobs to understanding health information, then really understanding SLD, advocating for early identification and the right kind of intensive intervention. It feels like it's not just an educational issue, it feels much bigger.
I think that's exactly right. It's a public health issue. It's an economic issue. It affects mental well-being profoundly. Addressing SLD effectively is really a critical societal responsibility impacting people across their entire lives.
A really vital perspective to end on. Thank you for unpacking that chapter with us.
My pleasure. It's complex, but so important to understand.
We really hope this deep dive gave you a clear, synthesized picture of specific learning disorder straight from a core psychiatric text. Thanks for joining us, and we'll see you next time on The Deep Dive.